Hi guys, I hope you're having a good time studying. This is a Usmle Step 2 CK. Let's read a few questions that is good. I mean, there's a few questions that this is good for you when you're driving and you can hear my voice and do like it's some kind of review while you're driving or doing stuff at home or at work or at any moment you can be in front of the computer you can hear my voice. So this is a good reviewing. So the next question they ask you your knowledge about anorexia nervosa, binge eating disorder, body dysmorphia disorder, bulimia nervosa, and generalized anxiety disorder. So the question said it's a female. It's a female girl. She brought to the doctor because she had been concerned about hearing her. I mean, her mom had hearing the daughter vomiting in the room, but she usually vomited sometimes when they have a lot of stress. She's trying to get into a very prestigious college recently, and she having a lot of stress. So, his BMI is at the his BMI for the age is at the fourth percentile, so it's really slow, really slow. So for the other things are okay, and physical examination she showed dental caries, bilateral parotid gland enlargement, and a scar on the dorsum of the right hand. Okay, that tells you something. So what do you think? With that history, which one do you guys pick of those one? So we got anorexia nervosa, binge eating disorder, body dysmorphic disorder, bulimia nervosa, and generalized anxiety disorder. So the people, most of the people have picked here. You can see anorexia nervosa, But most of the people, including me, we are confused about bulimia nervosa. There's many 24% of the people has picked that answer. In fact, this is a question that is easy because when most of the people pick over 50%, that means it's an easy question. If this question would be like a 30% pick this, 30 more person pick this, 30 more person pick this, 1% pick this. This is a very confusing question, a very hard question. But this is an easy question. So the answer here is anorexia nervosa. Let's read about that. So the eating disorders, the most common we have here in our test is anorexia nervosa, bulimia nervosa, and binge eating disorder. So the big difference between anorexia nervosa and bulimia nervosa, it is the BMI. That's what in the question they tell you the BMI. The BMI it was very slow, and the big difference for anorexia nervosa and bulimia nervosa, it is the BMI. The BMI must be less than 18 kilograms for meter square. So the BMI should be less than 18.5. If it is less than 18.5, you straight pick anorexia nervosa. Put in your mind that anorexia nervosa is when your BMI is less than 18.5. So most of the other things are almost kind of the same. That's why it is so confusing. So anorexia nervosa say you have intense fear of the weight gain. You have this distorted view of your body weight and shape. You think you was fat or something. Your belly is too big or things like that. So you have distorted view of the body weight and shape. Intense fear of weight gain. And the most important to differentiate from bulimia nervosa, it is a BMI less than 18.5. So the treatment for anorexia nervosa is cognitive behavioral therapy, nutritional rehabilitation, and we use olanzapine. if there is no response to the first line treatment. Olanzapine. Okay, so the other side, bulimia nervosa, they have almost the same of anorexia nervosa, the same clinical features. So recurrent episode of binge eating, you have recurrent episode of binge eating, you have binge eating and inappropriate compensatory behavior, like you vomit and you prevent to gain weight. You have excessive worry about body shape and weight. Like when you read it, you read kind of the same. Like this is confusing to me. So the big difference again, it is the BMI. The BMI tell you which wire you are from. So the treatment for bulimia nervosa is cognitive behavioral therapy, like the first one, nutritional rehabilitation, like the first one. So but in this case, the treatment is no olanzapine. The treatment is one of those SSRI, like could be fluoxetine, often in combination with the first line treatment. Okay, so SSRI, fluoxetine for bulimia nervosa. Okay, for the other side, we have a binge eating disorder. The binge eating disorder is a recurrent episode of binge eating with inappropriate compensatory behaviors. It's look like the bulimia nervosa sound the same to me, and lack of control during eating. So you cannot stop eating. So the treatment is cognitive behavior therapy, the same. This first line treatment for the three, all of them, the three is cognitive behavior treatment. And behavioral weight loss therapy, SSRI, and lisdexamfetamine topiramato. This is the treatment for binge eating disorder. That's the third line on treatment. So I want you to take in mind to learn that when they give you the BMI, if the BMI is less than 18.5%, you have to know the correct value. So let's review the correct value. So the correct value is from 19 to 25. From 19 to 25. It is easy because if the anorexia nervosa is 18.5, less than 18.5, so the normal value is from 19 to 25. Remember, BMI is body mass index. Body mass index. Sorry, body mass index. Body mass index. So making a calculation on your height or tall, on your weight, that's give you your body mass index. That the normal is between 19 to 25. 19 to 25. And anorexia nervosa is body mass index less than 18.5. Learn. Next question. For the next question, they ask you about which one is the best management for this case. The case is about a lady. She's para 2. She had been gravid 2 and para 2. She's a 26 years old woman, gravid 2, para 2. She was in the postpartum unit after incomplicated spontaneous vaginal delivery. She's now leaking a little bit amount of urine, involuntary. It has been 6 hours since she had the delivery, and the patient had been able to empty her gallbladder. So she was in the operating room. She was delivering a baby. 6 hours later, she's not able to urine. During the labor, she received epidural anesthesia for pain, for contractions and pain. In physical examination, they have a firm uterine fundus palpable at the umbilical and fullness of the tenderness above the pubic symphysis. So in physical examinations, you have like the uterus is a normal size after you deliver. It's normal to go under the umbilical, and so basically, this question is asking you: a young lady after delivering a baby, 6 hours later, she's not able to pee. So what's to do? The answer is urethral catheterization. Urethral catheterization. So the right treatment is urethral catheterization because this patient is having a urinary retention. So urinary retention. So acute postpartum urinary retention. By example, inability to avoid urinary dribbling. That's like a leaking a little bit of urine without you trying to pee. So are result from prolonged labor, perineal trauma, or regional anesthesia. In this case, they use anesthesia. That could be why she's having urinary retention. So just exactly how it is said here, epidural anesthesia is in labor impaired bladder function. So this give you urinary retention and overflow incontinence. The treatment is retention is to treat without short-term indwelling catheterization. So it's like the answers say put a catheter in. Just exactly how it say here, epidural anesthesia can cause postpartum urinary retention. Urethral catheterization is diagnostic and therapeutic. Postpartum urinary retention. The risk factors are primiparity, regional neuraxial anesthesia, operative vaginal delivery, perineal injury, and cesarean delivery. So risk factors for postpartum urinary retentions are primiparity, primary parity, like is your first baby. Primiparity, regional and neuraxial anesthesia, operative vaginal delivery, perineal injury, and cesarean delivery. So the clinical features are small volume of void or inability to void after 6 hours of done the delivery, or after 6 hours they take out the catheter, indwelling catheter during surgery. So small volume void or inability to void, incomplete bladder emptying, or dribbling of urine. Dribbling of urine is like a leaking urine, I think so. So the management is self-limited condition and intermittent catheterization. So this is the treatment, and this is the question that I was asking you. What's the management? So the first line management is self-limited condition. If this is the answer, that should be the first answer you pick. If it would be in there like an option, should be the first answer. If not, intermittent catheterization. So real quick, these patients has postpartum urinary retention, which is the inability to void 6 hours after vaginal delivery, okay, or 6 hours after the catheter removal following the cesarean delivery. So the risk factors include those ones that I already said. So on the treatment too. So let's see some others cause of the urinary retention. So we have here patients with acute bacterial prostatitis with urinary retention may require suprapubic catheterization of bladder. Okay, some other association with urinary retention is Guillain-Barré syndrome, is an ascending symmetrical paralysis over the days to weeks. There's autonomic dysfunction, there's tachycardia and urinary retention, and could be arrhythmias too. So all these associations with urinary retention is like acute spinal cord compression, where we have loss of the motor and sensory function, loss of rectal tone, and there's urinary retention. The management emergency surgical consultation and neuroimaging and possibly IV corticosteroids. That's an in that's another association of urinary retention. That's an acute spinal cord compression. Other association is medications like a 3-xyphenidil is a med used for Parkinson's disease, and drugs include extrapyramidal syndrome. Its anticholinergic effect can lead to a causal glaucoma, headache, and retroorbital pain. Other symptoms include dry skin, dry mouth, constipation, and urinary retention, flushing, vision change, and confusion. That's a medication for Parkinson's disease. Let's keep seeing more associations with urinary retention. So, diphenhydramine overdose. This diphenhydramine overdose. So, in diphenhydramine overdose, diphenhydramine overdose, we have drowsiness, confusion, anticholinergic effects like dry mouth, dilated pupils, blurred vision, reduced bowel sounds, and urinary retention. So another association with urinary retention is that diabetic autonomic neuropathy, diabetic autonomic neuropathy. So the diabetic autonomic neuropathy give you neurogenic bladder with urinary retention and distended bladder. All the causes are drugs and severe pain with a patient with a mild urinary obstruction, such as benign protracted hypertrophy, may cause urinary retention due to inability to well solve. The first generation H1 antihistaminics, such as diphenhydramine, have anticholinergic effect and can result in urinary retention from failure of the structure's contraction. So that's first generation H1 antihistaminics, like diphenhydramine, has anticholinergic effect and can result in urinary retention. Betanicol treat urinary retention, anatomic bladder. Imipramine, it is an antidepressant used to treat childhood aneurysms and to promote urinary retention. So the imipramine is antidepressant used to treat childhood aneurysms and produce urinary retention. And again, acute postpartum urinary retention is the inability to void urine after 6 hours of postpartum, and you have a sensation of globals in your abdomen, or in physical examination you can feel global over the pelvic symphysis, and inability to void. So you can see two urinary dribbling, that is like a leaking urine, involuntary, and the result from prolonged labor or perineal trauma or regional analgesia. The condition is typically related to bladder atony, which is temporary and reversible. the treatment, they want you to know that the treatment is a collocation of um, catheterization. Catheterization. Okay, let's see the next question. Okay, the next question is asking about which of the following action is most effective in improving the staff adherence of the recommended infection control practices. Infection control practices. So, which of the following actions most effective to improve the staff adherence to the recommended infection control practices? This is about a hospital that is having the committee is checking that the balance. Uh, the Hospital Quality Insurance Committee reviewed data including the high prevalence of healthcare associated infections caused by drug resistance enteric pathogen with the hospital. So they check that the people is not washing their hands. They don't do it. They don't do an adherence. They don't have an adherence to the recommended infection control. So the question's asking which of the following is the which of the following action is the more correct. So the correct answer is hanging brightly colored signs outside the patient's room specifying isolations, precaution type, and instructions. Hanging bright colored signs outside the patient's room specifying isolation, precaution type, and instructions. So, I have been in the hospital. I work in a hospital. I have seen in every door when there's a patient inside with some kind of infection, isolation infection, they hang a different tag with different colors. The color could be bright yellow, bright orange, bright green, and even brown. I think so, called brown. So every bright color tell you some kind of different isolation precaution. So the different kind of isolation precautions are airborne, contact, droplet, and standard. So we're gonna read each one, okay? So the different type of isolation precautions are airborne, contact, droplet, and standard. So the airborne. So in a group of the airborne, we have the bacterial tuberculosis. On virals we have chickenpox. That's the same one that produced the shingles later, because of reactivation, shingles or zoster, and COVID-19 too. This is airborne. So the key requirement for this is negative pressure run and N95 mask. Okay, in the contact group we have the MRSA, we have the Clostridium difficile, you have Escherichia coli. Clostridium difficile we call in the hospital C. diff. We have Escherichia coli, the high hex, the one 0157H7. Remember this one. This one is important. We have two rhinovirus. We have chickenpox virus, the one who produced the shingles and zoster. And so for this one, we have to use gloves and gowns on a single use, so it's like a very example stethoscope. Every time we use it, we have to clean it very well or reuse or no reuse it. Try not to reuse it. In the group of droplet, we have Neisseria meningitis, Haemophilus influenzae type B, Mycoplasma pneumonia, and then virus influenza or adenovirus. For this one, we use mask. Could be a single mask, not the one that 95, just single mask. And the standard precaution is like that we always have to have with each patient. It's followed with all patients, even if not infected or apparently infected. So you have to use hands hygiene. We have to use gloves and gowns and masks when it's appropriated. Okay, so isolation precautions, including contact, airborne, or droplet isolations, are essential in preventing healthcare associated infection in the hospital setting. However, the suboptimal compliance with those protocols can occur in very busy, complex setting, or in a place that is high patient volume, multiple demand on healthcare workers item, compromising the patient's safety. So that can be no the correct that could be like in the wrong place. Uh, we haven't when you having a lot of patients and just one doctor, so that could happen. So according to the principles of human factors engineering, uh, according to the principles of human factors engineering, processes should be designed to minimize human effort required to correct actions. So visual aids such as signs and on patient's door, it specify isolation precautions. So when we have all those kind of situation that everything is complicated, there's a lot of patients in the ER, or in your consult, like in your primary care. So posting those in the door, it's remind to everyone working in that place that they have to wash their hands, that they had to put your mask, they have to put your clothes perfect. You know, that's help a lot. So visual aids such as sign in on patient's doors specifying isolations precautions can increase adherence to by doing the following. So optimization environment design, reducing reliable in memory. Okay, so you don't have to keep her in mind. Just see in front of the door and say, oh yeah, I have to use a gun, I have to use a gloves, I have to use the 95 in this patient. So that help you. Just when you go into the room and you see that sign, you turn back and say, oh yes, I have to use a gun, and you turn back and you go to do the correct thing. So that help you to increase in attention through strategically placed alerts. Okay. Okay, let's do the next question. Let me so some uh some all the pathologies associated with the respiratory isolations is like a TB. In this case, always patients with hemoptysis, and high clinical suspicion for pulmonary TB should be placed in respiratory isolation. Another association with respiratory isolation is that patients with HIV who have subacute onset of low-grade fever, headaches, and signs of increased intracranial pressure should be evaluated for Cryptococcus meningitis. The diagnosis is established by detecting the Cryptococcus antigen or isolation of the organism in a legocephalorachidon. This is not associated with isolation respiratory. This is talking about only the situation type in HEB patients. Let's see next. Okay, this is talking about meningococcal meningitis. It is highly contagious. It's just talking about the kind of you know so meningitis, meningococcal meningitis is a highly contagious disease that can lead to devastating complications and outbreaks of the community. So the treatment involves isolation, like the subject that we're talking about. So the treatment involves isolation. So IV antibiotics and supportive care in an intensive care setting to monitor disease progression. A patient who doesn't comply voluntarily need to be hospitalized against his or her wishes. So this is like a community emergency that the person having meningococcal meningitis have to stay in the hospital if they don't want. They have to stay in the hospital because they're a big risk for the whole community. It's very contagious disease, and they have to stay in the hospital. It is ethical for the doctor to isolate a non-compliant patient until the patient no longer possess the risk. Okay. In another word, resume. So system should be designed to minimize the effort required for safety action by healthcare workers. Adherence to the isolation precautions can be increased through strategically placed visual aids. For example, bright colors signs outside of the patient's door, which increase attention and reduce reliance on memory. Very helpful. Okay, the next question is a lady. She was she was camping yesterday. While she was putting her pants, she feels something bite her on her thigh. Everything looked to be okay, but examination, she have a erythematous painful ulcer on the lateral of the upper thigh, on the right thigh. So they want us to know what's going to happen with that wound. So which of the following complications is most likely to develop in these patients over the next few days? So the options are abdominal rigidity, muscle cramp, B, arthritis, arrhythmia, and facial palsy. That sound like a Lyme disease. C, hemoglobinuria and bleeding. D, muscle paralysis, and E, necrosis and HR. So the answer here is E, obviously E. What's gonna happen is necrosis and HR. So what is the explanation? Let's see. This patient's clinical presentation is a small ulcer developing at the site of the recent bite. It is highly suggested a brown recluse spider bite. Brown recluse spider bite. Such bites commonly occur in patients are putting their clothes on. They are often painless and may initially go unrecognized, but some bites are painful or cause a burning sensation. Many cases result in small papilla that heal in days to weeks. However, in some cases, a deep skin ulcer develop at the right side over the course of few days, with an erythematous halo and a necrotic center that can progress to an eschar. So I can see here some images about brown recluse spider. So those are some kind of brown recluse spider bites. They are like the signs of a nickel or a penny. No, it's nickel. Nickel, 10 cents. Oh, they are pretty. So let's see what they have to do, what they have to say here in this text. So, management of bites and stings. So, we knows about bees and wasps. They can produce anaphylaxis. The management is antihistaminics and steroids, intramuscular epinephrine if anaphylaxis develops. So that's con respect to bees and wasps. So the spider, we have two principal spiders here. We have the black widow, and we have the one that we're talking about right now, the brown recluse. The brown recluse produces you a necrosis, flu-like symptoms, disseminated intravascular coagulation. The brown recluse give you necrosis, flu-like symptoms, disseminated intravascular coagulation. So the management from this brown recluse spider bite is cold cold compress, uh, cold compress to lower the necrosis, and they can give Dapson too, to help, uh, to help. So this is contraindicated in patients with GCPD, uh, glucose 6 phosphate dehydrogenase deficiency. So you don't give Dapson in patients that have a G6PD deficiency. So the treatment of the necrotic tissues too. So that's the treatment for brown recluse spider bite. So for the black widow, we have muscle spasms. That was one of the options. Let's see. That was one of the options. Muscle spasms. Oh yeah, the number one, abdominal rigidity and muscle spasm, muscle cramps. That probably is the talking about the black widow. We're gonna read that about that. So for the black widow, that's gonna give you muscular spasm on sorry, you probably wasn't seeing this imagine before. So was talking about the bees and wasps. I don't know how to say this word. Wasps, bees and wasps, and they give you anaphylaxis. If the anaphylaxis is too big, you can get intramuscular epinephrine. So you have two kind of spiders. We have here the spider black widow and the brown recluse spider. So the black widow can give you muscular spasm. It can mimic a rigid acute abdominal, but no rebound. Okay, can give you rigid acute abdominal. This is important because they can give you a history that you think they're giving you a peritonitis. They don't give you a peritonitis. They're giving you a black widow sting, a black widow spider's stick or bite. I mean, so again, the black widow can give you muscular spasm. They can mimic a rigid acute abdominal, but no rebound. Remember, when you have the rebound of appendicitis, peritonitis, you have rebound. So the black widow management is antivenom. Antivenom. The classic treatment with calciogluconate is largely proven ineffective. So the classic treatment with calciogluconate is hardly proven, is largely proven ineffective. So if the one of the answers questions they have a calcium gluconate, so don't pick calcium gluconate because they prove that it is ineffective. So antivenom, this is the answer for a black widow. Okay, let's keep going. Okay, talking a little bit about the black spider, the black widow spider, the black widow spider. So the black widow spider often lead to more pronounced local and systemic manifestation due to the effect of the toxin. So they have a toxin, so they are worse. So those include muscle pain, abdominal rigidity, and muscle cramps. The wound ulceration is uncommon, and patients commonly develop nausea and vomiting within an hour of the bite, making this an unlikely diagnosis in this case because this case you just have an ulcer. So again, the black widow spider it leads to more pronounced local and systemic manifestation due to effect of the toxin. Those include mucous spasm, a prominent funding, muscle pain, prominent funding, abdominal rigidity, sometimes mimicking a surgical abdominal, abdomen, like appendicitis, but they don't have a rebound. And muscular cramps, seen in more than 60% of the patients. Wound ulceration is uncommon, and patients commonly develop nausea and vomiting within an hour of the bite, making this, in this case, more unlikely. Like we said before, patients with arthritis, arrhythmias, and facial palsy can occur in late complications of Lyme disease. Arthritis, arrhythmias, and facial palsy can occur in late complications of Lyme disease. Those typically do not develop until months after the tick bite. The initial rash, you're gonna have erythema migrans. It is classically a target lesion with the central clearance. No, there's no ulceration in this one. Okay, let's just to remember the brown recluse spider bite can cause a deep necrotic ulcer at the site of the bite. The ulcers can progress to over days to an eschar. I don't know how to say this word. Let me find how it look. Okay, so he said the eschar is a black on the skin. It's a black of dead skin, like a necrosis. It's very similar to necrosis, but they have a different name. So an eschar is a piece of dead tissue that is cast from a surface of the skin, particularly after a burn injury, or but can be also gangrene ulcer on fungal infection, necrosis, spider bites too. Yeah, that's a shark. Okay, it's like a dead of the skin in that place. Okay, so let's keep the next question. So the next question is this little girl. Uh, she she fell on a trampoline and put her hands straight down, and after that she having a lot of pain, and they show you this image in here, and they said an X-ray they said there's a fracture of the humerus and supracondylar area, and the distal part of the humerus is moved to the distal is moved to the back. So X-ray revealed a supracondylar fracture with posterior displacement of the distal humeral fragment, as shown in the image. So now they ask you, what's the next? What's the next situation? What is affected? They give you a couple options. Let's see what else the options are. Let's see. They give you those options. Which of the following is affected in this case? The axillary artery, the axillary nerve, the brachial artery, the brachial plexus, and the ulnar nerve. Most of the people have picked ulnar nerve, but the correct answer is a brachial artery. Yeah, brachial artery. 45% of the people, even if 49% of the people have picked ulnar nerve. So let's see why they want us to know that. So why is brachial artery is no ulnar and is no ulnar nerve? So very clear, I can see why not, because the one who goes just in front of the distal part of the humerus is not the ulnar. It is the median nerve. I was thinking about that because it's the median nerve, but the median nerve is not one of the options. So I decided to pick one of the nerves, but exactly the one you to know that is the brachial artery, this one here. So the one who could get affected in a fracture here is the brachial artery and the median nerve. So in those options, the only options that is they asking you is brachial artery. So you had to pick what brachial artery. If they give you the median nerve, then you pick the median nerve. But this is only two because she had a fracture exactly here, and you can see here the median nerve and the brachial artery just go in front of the distal part of the humor. So supracondylar fractures. So supracondylar fractures of the humerus are the most common elbow fractures in children. The mechanism typically involves a fall into an stretched hand with a hyperextended elbow. In this case, the distal part of the condylus, the distal part of the humerus go to the back and have very like relation neurovascular entrapment in a brachial artery and a median nerve. So the supracondylar area is relatively thin and weak due to the physiological remodeling during the childhood growing, and a supracondylar fracture most common result in posterior displacement of the distal humeral fragment. So when you the supracondylar fracture most commonly result in posterior displacement of the distal humeral fragment, as seen in these patients. When you have like a fall with that out straight when you hand straight, so this usually go posterior. So the anterior displaced proximal fragment can entrap the median nerve and the brachial artery, which are localized anterior to the humeral. Okay. So now that we're talking about those kind of injuries, let's review real quick some other upper extremity and lower extremity lesions. So the anterior dislocation. So we got here shoulder dislocation. In shoulder dislocation, we can have an anterior and posterior. If you have an anterior, is the most common, 95%. The risk is axillary nerve injury. So posterior dislocation is rare, is associated with seizures and electrocution. Patients come with their hands, abduction, and internal rotation. And last, the displaced supracondylar fracture of the humerus most commonly present after a fall into an outstretched hands with a posterior displacement of the distal humerus fragment. The anteriorly displacement proximal humerus fragment can entrap the brachial artery and the medial nerve, which pass anterior to the humor. The anteriorly displacement of the proximal humeral fragment can entrap the brachial artery and median nerve, and that produced. That's the question. The question is asking about the brachial artery. Okay, thank you guys for being here, and if you keep watching those kind of videos, more coming soon. Thank you very much.